of PMC Nair, sir. Good evening, sir.
Hello, good evening.
Good evening, sir.
Okay, yeah, thank you.
Okay. So we'll quickly move on to the proceedings. I'll hand over the session to Dr. Aswathy for moderating. And once I think Dr. Neethu presents, Dr. Bindusha will come in and give her views, and then we can all pitch in as well. Thank you, Dr. Mohandas, sir. I'll hand over to Dr. Aswathy.
Okay, thank you, Arun. Happy Vijayadashmi to all. Vijayadashmi or Dasra, actually, it is a victory of good over evil. We are remembering two mythological victories. One is Rama over Ravana, and another is goddess Durga over Mahishasura. So on this auspicious day, we also thought like we will take a topic for which mankind is trying to get victory over the last more than a century, that is tuberculosis. So our National Tuberculosis Elimination Program is a flagship program of Government of India for eliminating TB by 2025. Actually, 5 years, the plan is 5 years ahead of the global target year of 2030. So among clinicians, I think neonatologists are the persons who are least encountering TB patients. By the time we suspect TB, the baby will be an infant. So so we are actually least bothered about the national programs also, all this. So I invited Dr. Bindusha, who is a professor of pediatrics, SAT Hospital, Trivandrum, for chairing the session on this topic, that is perinatal tuberculosis. And our first year DM resident, Dr. Neethu CS, will be presenting a short summary of National Tuberculosis Elimination Program and how to deal with the perinatal tuberculosis in a neonate. Over to Dr. Neethu.
Okay, ma'am. First, we discuss about NTEP and perinatal tuberculosis. First is National Tuberculosis Elimination Program. Little bit about National Tuberculosis Elimination Program. Actually, it is a centrally sponsored scheme implemented under National Health Mission, technical and managerial leadership to anti-tuberculosis activities in India. It actually came into effect from 1st January, renaming RNTCP, flagship program that steers the country to the goal, the TB Freedom India by 2025. Actually, it's a 5 years ahead of Sustainable Development Goal. This is an organogram of NTEP. There is a central TB division, then followed by a state TB cell, then district TB center, then TB unit, and peripheral health institution. Actually, it is a centrally sponsored program. At national level, it is managed by Central TB Division, the technical arm of Ministry of Health and Family Welfare. And at state level, there is a state TB cell that coordinates the overall TB elimination program in the state under the guidance of State Health Society. The training, supervision, monitoring, evaluation of NTEP at state levels are looked after by State TB Training and Demonstration Center. At the district TB center, it is a nodal point for all TB elimination activities in the district under the guidance of the District Health Society. Then there is a tuberculosis unit level. NTP activities at block, sub-district levels are implemented through tuberculosis unit, which comprise designated medical officer supported by 2 full-time NTP staff, that is senior treatment supervisor. Then followed by a peripheral health institute. Actually, it is a health facility manned by a medical officer. All private health facilities like private practitioners, private hospitals, clinics, nursing homes are also peripheral health institute. This is an algorithm of a baby born to mother having TB. Initially, we have to rule out active TB. First, if there is no signs or symptoms of TB, then test for TB infection. Then evaluate for TB prevent therapy. And then start TB prevent therapy and then systematic follow-up. If there is any presumptive TB, that is TB is confirmed, start TB treatment, then systematic follow-up. And if there is no active TB ruled out, then we can go to TB preventive therapy. How can you rule out active TB? By chest X-ray, USG abdomen, and CBNAT. Chest X-ray and USG abdomen findings are dealing later. Then CBNAT. Initial in newborns, gastric lavage is usually preferred. Actually, it should be collected by a skilled healthcare worker. Minimum amount of 2 to 5 ml, and should be collected in a sterile container. And collected specimen should be transported to the lab as soon as possible. If there is any delay, it can be refrigerated up to 1 week to inhibit the growth of unwanted microorganisms. This is the NTEP request form for examination of biological specimen for TB. Actually, this request form is kept at all peripheral health institute. It is filled generally by MO of referring health facility. Then collection of CBNAT. It's usually done in a district TB center, TB units, and medical colleges. After this, all the cases have to be entered in a peripheral health institute TB notification register. If they are not notified in NICSHI, MO and staff should notify them. This is a NICSHI. It is an integrated ICT system for TB patient management and care in India. Actually, it was launched in 2012, and since then, various improvement has been made in this system. Actually, NICSHI version 2 has been launched in September 2018. What are the features of NICSHI healthcare providers? Different types of login like state, district TB units, peripheral health institute, staff logins, private providers, chemists, and patient provider support agency, joint effort for elimination of TB, and also integrate all adherence and technologies such as DOTS and medication event reminder monitor. And also there is a unified drug sensitivity TB and drug resistant TB data entry form. It is there is a mobile friendly website with a mobile app. This is an example, a patient name that is Chandran, that is entered. They have a unique patient ID, and they all the NICSHI ID, and they enter all details. And also in the app, they have included all the enrollment test, treatment details, follow-up details, adherence statistics, adverse events. All these can be seen in the NICSHI app. And also they provided TB identity card for all patients. And also for TB preventive therapy, they issue another TB preventive therapy card. And also if a TB patient, they issue IPT card also. Then a little bit about programs under NTEP. Pradhan Mantri TB Mukt Bharat Abhiyan, NICSHI 2.0, that is the latest version, NICSHI Mitra, and NICSHI Poshan Yojana. This is Pradhan Mantri TB Mukt Bharat Abhiyan. These are the objectives of Pradhan Mantri TB Mukt Bharat Abhiyan. It actually provides additional patient support to improve treatment outcome of TB patient, and also augment community involvement in meetings India's commitment to end TB by 2025 and leverage corporate social responsibility opportunities. NICSHI 2 already we discussed, a digital platform for community support and persons with TB. Then next is NICSHI Mitra. What is NICSHI Mitra? It's actually donor for TB patients on TB treatment. Who can be NICSHI Mitra? Individuals, elected representatives, NGOs, institutions, both public and private, industry association, and corporate. Is consent of TB patients is required for providing support to them? Yes, it's required. It can be done electronically while enrollment or manually. The next one is NICSHI Mitra. What support NICSHI Mitra provide to TB patients? It actually provide nutritional support. That is dry rations, vocational support, and pre-treatment investigations. What is the procedure for being NICSHI Mitra? NICSHI Mitra have to register themselves on NICSHI portal and select state and district for providing support to TB patients. This is Pradhan Mantri TB Mukt Bharat Abhiyan at a glance. That who can be NICSHI Mitra? Cooperative societies, corporates, elected representatives, institutions, NGOs, political parties, individuals. What are the types of supports to be provided by NICSHI Mitra? Nutritional support. They provide diagnostic, vocational, additional nutritional supplements. What is the duration of support? 6 months, 1 year, sometimes 2 years, 3 years. What kind of geography types to be supported? State, district, block, peripheral, health institution. Other services under NTEP, they provide some incentives. Private providers around 1,000 rupees for notification, 500 rupees, and 500 rupees on treatment outcome, and patients 500 per month. And for tribal patients, they provide 750 rupees, and treatment supported 500 rupees on notification, 500 rupees on treatment outcome. Informant 500 rupees for notification. And the TB should be mandatory to notify from the laboratories, private practitioners, and hospital chemists. Public health action by staff counseling, home visit, treatment adherence, and also in adult HIV and diabetes mellitus screening also. Then next about Pradhan Nikshay Poshan Yojana, beneficiaries, all TB patients notified, benefits 500 per month till completion of treatment, payment direct to bank or postal account of patients. To reduce the transaction, 2 months incentive may be club. First incentive that is given 1,000 as advance, and then till completion of treatment. Then finally, any practitioner treating a patient for tuberculosis is assuming an important public health responsibility to prevent ongoing transmission of infection and the development of drug resistance. To fulfill this responsibility, the practitioner must not only prescribe an appropriate regimen, but when necessary, also utilize local public health services, community health services, and other agencies, including NGOs, to assess the adherence of the patient and to address the poor adherence when it occurs. This is a services for private sector patients through NGO by NTEP. First one is sputum collection from private sector for NTEP. Then free NAT test services for private sector patients through private providers and NGOs as an interface. Then followed by Nikshay notification. Then treatment, that is fixed drug combination. Then linkage to NTEP. Then they provide counseling of patients and family. Then adherence. This about National Tuberculosis Program. Then come to perinatal tuberculosis. What do you mean by perinatal tuberculosis? Actually, tuberculosis in neonates most commonly postnatal, can occur via horizontal transmission from mother or caregivers. It's actually difficult to identify the exact route of transmission. But collectively, this perinatal tuberculosis is referred to as congenital or postnatal TB in clinical practice. Actually, this incidence and prevalence varies. It's actually estimated vertical transmission from a TB infected mother could be as high as 16%. Estimated data of 20,000 to 40,000 Indian pregnant women are likely to have TB each year and contribute around 3,200 to 6,000 cases congenital TB each year. This is from NNF. Actually, best way to prevent perinatal TB is through early diagnosis and treatment of maternal TB infection. What are the effects of TB on mother and child? Actually, maternal mortality rate varies from 40 to 100%, with higher mortalities associated with the delayed diagnosis and inappropriate treatment. Then it's associated with a twofold increased risk of fetal distress, prematurity, low birth weight, small for gestational age, and also increased risk of perinatal death. Then congenital TB. How this congenital TB occurs from the mother, it is transmitted through from the infected placenta to reaches the umbilical vein. Then in utero, this aspiration of amniotic fluid and infected from the placenta or endometrium that reaches the baby. Postpartum, ingestion of infected amniotic fluid or secretion from the maternal genital lesions, and also during delivery. Postnatal TB, that is most common, that is usually from infected mothers or from infected caregivers. This is the pathophysiology. It's perinatal, that is from the cervicitis or vaginitis, baby had TB, and prenatal, that is placentitis, that causes hematogenous spread and also aspiration of infected amniotic fluid, that causes TB, and postnatally mainly pneumonitis, that is airborne inoculation. And also outside contact, that is nursery personnel, household or family contacts also can cause TB in newborns. Actually, pregnant woman who gets primary TB infection during pregnancy, who develop reactivation of latent TB infection can have placental dissemination, such risk of transmission of fetus. With more severe congenital infection, secondary to primary infection in the mother. Extrapulmonary miliary disease, genital TB in the mother is also associated with the perinatal TB, that is increased risk of perinatal TB. Actually, why it is a challenging situation in neonate? Actually, in newborns, there is non-specific signs and symptoms. Actually, clinical presentation is similar to that like a sepsis or other intrauterine infections. Majority of the mother with the TB during pregnancy are usually asymptomatic. Many as half to two-thirds of mother remain undiagnosed till their infant diagnosis. Then how will you suspect a perinatal TB early? Infant with a respiratory distress or a hepatosplenomegaly and fever during the first 3 months after birth. If the infant not responding to multiple antibiotic treatment and other congenital viral infections have ruled out. And also chest imaging show miliary pattern, especially after 4 weeks of postnatal age. Initially, etc. were normal. Then abdominal imaging show multiple focal lesions in the liver and spleen. Because this TB bacilli that enters into the umbilical vein then reaches in the liver. Liver is a primary focus. Then mother having active TB during pregnancy. These are the clinical signs and symptoms of congenital TB. Fever, respiratory distress, hepatomegaly without splenomegaly, sometimes lethargy, poor feeding, failure to thrive, cough, cyanosis, lymphadenopathy, jaundice, abdominal distension, ear discharge, skin lesions, vomiting, seizures. Most common clinical symptoms are non-specific and may mimic neonatal sepsis or other congenital infection. Hepatic involvement with altered liver function and respiratory symptoms are the two major systems in congenital TB. Actually, placental lesions in the perinatal TB include chronic necrotizing granuloma in the deciduum or endometrium of the uterus. Majority of the congenital TB usually present within the 3 weeks, though diagnosis can be made as late as 148 days, that is around 5 months. Usual diagnosis can be made by some well-known criteria, that is Campbell criteria. This congenital TB may be diagnosed in the presence of proven TB disease such as positive smear or culture and any one of the following conditions like lesions in the newborn within the first weeks of life, primary hepatic complex or caseating hepatic granuloma, TB infection of placenta or maternal genital tract, exclusion of possibility of postnatal transmission by investigation of contact, including hospital staff. Actually, there are some limitations of Campbell criteria. Late clinical presentation in neonate beyond 2 to 3 weeks, not uncommon. Difficulty in demonstrating FB bacilli in neonate from sites other than gastric aspirate. Placenta and endometrium examination sometimes difficult. Difficulty in performing percutaneous liver biopsy in a sick newborn. And also incomplete evaluation of mother or caregivers when symptoms not florid in either. This is some lab findings, but non-specific. Leukocyte count more than 12,000 per microliter, that is around 64%. Neutrophil count more than 50%. Some HB less than 10. Thrombocytopenia, elevated ESR, elevated CRP, post-tuberculin test around 13%. Then chest X-ray. The most common imaging modality. This is features of congenital TB like alveolar pneumonic opacification. There is miliary infiltrate, bilateral bronchopulmonary bronchopneumonic infiltrate, intrathoracic lymph nodes, pleural effusion, cavities, sometimes normal chest X-ray that is usually seen 5 to 10% of newborns. Then postnatal acquired TB is also similar to that of congenital TB, but some difference in X-ray, that is mediastinal lymphadenopathy, large airway compression, lobar unilateral hyperinflation, collapse due to partial or complete large airway obstruction by enlarged mediastinal lymph nodes and Cohen's pocket. Then followed by abdominal ultrasound, hypoechoic lesion in the liver and spleen. Intra-abdominal or retroperitoneal lymphadenopathy. Ultrasound guided biopsy. In case of CNS TB, we can do LP, brain CT or MRI also need. To confirm congenital TB, examination of the placenta, tuberculosis in mother, then endometrial biopsy of the mother. These are the diagnostic tests usually not done in newborns. Actually, first one is tuberculin sensitive test, skin test. That is in less than 3 months, it's high chance of false negative. So it is not recommended. IGRA, that is interferon gamma release assay. See, almost always negative in newborn due to immature T lymphocyte activity. So it is not recommended. AFB, smear detection of gastric washings, tracheal, alveolar lavage, pleural, CSF urine. Also, the yield is poor. Then next, culture. Actually, also poor yield, seldom positive. Liquid media culture facilities growth, but takes around 3 to 6 weeks to grow. Can be used. And most commonly, we use CBNAT using PCR. It's a rapid technique, even with a low bacterial count, even can detect isoniazid and rifampicin resistance. 88% sensitivity and 98% specificity. It's highly recommended if available. Then these are the two important findings. That is presence of caseating granuloma in the liver or evidence of tubercular infection of the placenta is diagnostic of congenital TB. Then how will you manage and follow up of this baby? There are 3 different scenarios. First scenario is symptomatic infant with a clinical suspicion of TB infection. Second scenario is if a baby born to mother with a latent TB infection during pregnancy. Then third scenario is if a baby born to a mother with active maternal infection during pregnancy. First scenario, that is symptomatic infant with a clinical suspicion of TB infection, complete diagnostic evaluation, start treatment. Mother and family members should be screened for evidence of active TB. This is a regimen, that is 2 HREs, isoniazid, rifampicin, pyrazinamide, ethambutol, and then followed by 4-month HRE, total 6 months. Actually, therapy is based on body weight, that is 4 to 7 kg, starting from 4 to 7 kg, and based on this we can fix a drug combination, we can give that baby. And this is a rough estimation of range, that is rifampicin usually we give 15 mg per kg per day, isoniazid 10 mg per kg per day, pyrazinamide 35, and ethambutol 20 mg per kg per day. But in some special situation like CNS TB or skeletal TB, the duration is extended up to 12 months. That is 2 HRSD and 10-month HRE. Corticosteroid should be added in confirmed TB meningitis at 2 mg per kg per day of prednisolone for first 4 weeks and then tapered slowly over the next 4 weeks. Then next scenario, that is a baby born to mother with latent TB infection during pregnancy. Mother is asymptomatic with a positive tuberculin sensitivity test and normal chest X-ray. The neonate need not be separated from the mother or worked up for TB infection, and breastfeeding should be continued. Screen other family members for active infection, and mother should be considered for isoniazid or isoniazid plus rifampicin during pregnancy if there is recent TST conversion, a recent contact with a contagious person, or immunocompromised. Infant should receive BCG vaccination at birth. Then the common scenario, that is a baby born to mother with active maternal infection during pregnancy. First, the mother should be started on treatment, ruling out active TB. This is after ruling out a TB, if the baby is not, this CBNAT is negative and chest X-ray is normal, abdominal ultrasound is normal, we can go for a TB preventive therapy, that is TPT. Actually, there are different types of TPT for children. That is 3 months. That is weekly for 3 months. That is isoniazid plus rifampicin. Then isoniazid. That is 6 months. For 6 months. Then month
Neethu,
daily
Neethu,
one. That is 1 month
Neethu?
daily rifampicin. Daily.
Neethu, ഒന്നുകൂടെ
Yes.
റിപ്പീറ്റ് ചെയ്യ്, വോയിസ് ബ്രേക്ക് ചെയ്യുന്നുണ്ട് ഇടയ്ക്ക്. ഹലോ,
Okay, madam.
വോയിസ് ബ്രേക്ക് ചെയ്യുന്നു, ഒന്നുകൂടെ റിപ്പീറ്റ് ചെയ്യോ?
It is WHO recommended TPT for children. Actually, okay. Clear now, ma'am?
നീതു പറഞ്ഞ ആരും കേട്ടില്ല. നീതു ഒന്നുകൂടെ പറഞ്ഞോ.
അതെ, ബ്രേക്ക് ചെയ്തു പോന്നു. നെറ്റിന്റെ പ്രശ്നമാണോ?
അതെ, നീതു കേട്ട ഈ സ്ലൈഡ് മുഴുവൻ റിപ്പീറ്റ് ചെയ്യും നീതു. എനിക്ക് തോന്നുന്നു കണക്ഷന്റെ പ്രോബ്ലം ഉണ്ട്.
നീതുവിന്റെ കണക്ഷൻ പോയി തോന്നുന്നു ഇല്ലേ?
കേൾക്കണില്ല.
അല്ല, സ്ലൈഡ്സ് നമുക്ക് കാണാമല്ലോ.
പക്ഷെ വോയിസ്
Regimen
നീതു കേൾക്കണില്ല. നീതു എന്തോ വോയിസ് പ്രശ്നമുണ്ട്.
ഈ സ്ലൈഡ് വേണമെങ്കിൽ എനിക്ക് തോന്നുന്നു ഞാൻ എക്സ്പ്ലെയിൻ ചെയ്യാം. എന്നാ നീതു ഇപ്പൊ കേൾക്കാമല്ലോ. നീതു
കേൾക്കാം.
അപ്പൊ
ഇപ്പൊ
ഇപ്പൊ
കേൾക്കാം.
സ്ലൈഡ് പോയി.
സ്ലൈഡ്.
രണ്ടാമത് ലോഗിൻ ചെയ്തിട്ടേ മാഡം, അതായിരിക്കും നല്ലത്.
ഓക്കെ.
ബിന്ദുഷ പറഞ്ഞോളൂ.
But WHO has actually recommended multiple regimens for prevention of tuberculosis, and they have advised that each country or region can select their own regimen. Some of these regimens that the WHO has recommended is for specific purposes, and some are for actually for general, for any patient in whom we want to give treatment for TB infection. The common regimens that the WHO has recommended, and they used to give us 6H, that means 6 months of INH alone. That can be given, that is still recommended. Then you have 3 months of INH with rifampicin. That is the regimen that Kerala has opted, and from 2019 onwards, we are actually giving this regimen only. That is 3 months of INH plus rifampicin for all patients, or pediatric patients in whom TB infection treatment is required. That is what we are giving. Then you have 3 months of weekly INH plus rifampicin. This is the regimen that is recommended by the NTEP for pediatric and also adult patients in whom we have to give treatment for latent TB or TB infection. For any patient above 2 years, they recommend this regimen. And for in the national guidelines, they recommend 3HP for patients about the age of 2 years and 6H for patients below the age of 2 years. Okay, I think Neethu will explain why we are giving the different regimens. Neethu, you can go back to the previous slide and start explaining. Okay.
ഇത് ആ സ്ലൈഡ് തൊട്ട് തുടങ്ങിക്കോ, റെജിമെന്റ്സ് ഉള്ള സ്ലൈഡ് തൊട്ട്.
This is the latent TB treatment regimen. WHO recommended TPTs for children. Actually, we prefer 3-month daily isoniazid and rifampicin. While in Kerala, we prefer 3 months daily isoniazid plus rifampicin. Why? Because comparatively lower risk of adverse effects compared to longer duration of isoniazid along regimen. And there is chance of greater adherence due to shorter course and familiarity of use for pediatricians and availability of child-friendly fixed dose combination in place of adequate system to rule out active TB. If the infant is HIV exposed, that is mother is HIV infected, and on nevirapine, isoniazid should be started instead of 3-month isoniazid plus rifampicin. And also TPT with the 4-month rifampicin and 3-month rifampicin and isoniazid cannot be given along with the nevirapine prophylaxis, since rifamycin decreases the nevirapine levels and may result in increased mother-to-child transmission of HIV. This is a fixed drug combination, isoniazid plus rifampicin, that is starting from 4 kg, 4 to 7 kg, that is one drug, that is 75/51. Then any other contraindication of TPT is, if there is active TB, TPT is contraindicated. Acute or chronic hepatitis, TPT is contraindicated. Concurrent use of other hepatotoxic medications like in newborns, nevirapine is also contraindication. Allergy or non-hypersensitivity to any drugs being considered for TB preventive therapy. Then along with this isoniazid plus rifampicin, we usually give pyridoxine. Pyridoxine, it is available in tablet, 5 to 10 mg per day. And then follow up. How will you follow up this baby? So actually, baby should be reviewed every month for those on 3-month regimen. If it is a 6-month regimen, you should follow every 2 months. Then actually drug-resistant TB preventive therapy, ideally at a healthcare facility or treatment supporters. If possible, aligning visit with the care for the index patient is an important consideration. This is our baby. This is baby of Adira. Actually, baby admitted in OBN postnatal day 1 in view of respiratory distress. Actually, after admission, the baby had respiratory distress person and get intubated, and X-ray was normal. But after admission, the mother went to casualty in view of some discomfort and diagnosed her some bradycardia. In OBS casualty, they take ECG and X-ray. This is the X-ray of the mother. And X-ray, they're suspicious of TB, biliary TB, and they take HRCT also, and also CBNAT. Then sputum AFP is positive, CBNAT positive, and then HRCT suggestive of biliary TB. And this baby of Adira, we gradually weaned from oxygen, and then we did gastric CBNAT, and X-ray was normal, and gastric CBNAT was negative, and we sent to the RNTCP for treatment. They advise to start fixed drug combination, that is isoniazid plus rifampicin based fixed drug combination. That is 1/3. Initially started 1/3, and advised them to follow. And also they get a Nikshay ID, that is 16518766663. That is ID also, they get ID from the RGCP. Then monitor TB symptoms and evaluation for TB disease if any symptoms or signs suggestive of TB. Then monitor weight to check appropriate TPT dose, TB preventive therapy dosage. Then monitor and manage any adverse events of a TB preventive therapy, CBC, LFT, RFT, and monitor for adherence to treatment and conduct pill counts. Then breastfeeding. Actually, breastfeeding women should receive a full course of TB treatment. Breastfeeding must be continued. After ruling out active TB preventive therapy can be started. Mother receiving isoniazid and their breastfed infants should be supplemented with the pyridoxine. That is, dose is 5 mg per day. And also mother should be advised about cough hygiene measures, covering the nose and mouth while coughing, sneezing, or any act which can produce the sputum droplets. Then vaccination. All routine vaccination can be given as per schedule. As per RNTCP, BCG should be given at birth even if the infant's receiving isoniazid prophylaxis. Then there are some prognostic factors, that is factors associated with poor outcome. That is, age at onset of symptom is less than 3 weeks. It is a poor, it indicate poor prognosis. Intracranial involvement, that is CNS TB. Then miliary pattern and multiple pulmonary patterns in chest X-ray. Then elevated leukocyte count and lack of treatment is also a poor prognostic factor. This is all about TB and perinatal TB.
Okay.
Bindusha,
Thank you, Neethu. Neethu, can you please explain, should we actually isolate a mother with tuberculosis? Mother had tuberculosis and she delivered a baby. Should you isolate?
If a mother having active TB, then isolate the baby from 2 weeks.
Okay, if the mother was started on tuberculosis treatment, ATT, at least for 2 weeks, then there is no need to isolate if the mother is having drug sensitivity. Okay, the most important factor which determines whether this mother should be isolated or not are, first is the sensitivity of the drug, of the what do you call tuberculosis bacilli. If it is a drug resistant TB, definitely you need to isolate. If it is a drug sensitive TB and the mother is started on your ATT and the baby was started on your TB preventive therapy and the mother is adherent to your treatment, then there is no need for you to isolate the mother. And we can also continue the breastfeeding. And also another thing is that during the treatment schedule, mother actually has to follow the cough etiquette, right? Cough hygiene should be followed. Even if we are not isolating, the mother should take all the precautions to prevent the bacilli from spreading from her. Even though we feel that after 2 weeks, the number of bacilli which the mother can spread is very low. Even then, the mother has to follow the cough etiquette. Okay.
And the first 2 weeks even drug sensitive ആണെങ്കിലും first 2 weeks
First 2 weeks, it is better to isolate. If the mother treatment was started before pregnant and before delivery, then there is actually, if 2 weeks have already over, then there is no need. Otherwise, in the initial 2 weeks, it is always better to isolate. After that, there is no need to isolate if the mother is following the drugs. Okay. And then another question is, Neethu, what are the factors which will actually affect the transmission of TB from the mother to the baby? When will the transmission increase? Any factors which will favor the transmission of tuberculosis?
Initially, if there is a mother having TB, then during at the time of there is infection, the placentaitis, there is placentaitis that is transmitted by umbilicus and reaches in the liver. And second mode of transmission is through the amniotic fluid ingestion of the ingestion of the secretions. And then the third transmission via if the mother having pneumonitis, mother having TB, or at the time of delivery from the infected materials through the birth canal also can cause TB.
Okay, Neethu, as you said, the baby can get infected through different routes. It could be during the intrauterine life, it could be perinatal or postnatal. What I was asking was that what are the factors which would favor the transmission? Okay, I think you discussed this during the presentation. Just to emphasize that one of the most important factor is the type of tuberculosis in the mother. What is the disease the mother is having? If the mother is having miliary tuberculosis, primary infections, especially miliary, meningeal, and extensive pulmonary diseases, then there is a high chance that this baby may also be infected. Okay. Suppose the mother is having only lymph node tuberculosis or just a pleural infusion, then the chance of transmission actually decreases. So the severity is one thing that will affect. Okay. Then another thing is that when the ATT was started, suppose the mother received ATT treatment, and usually before in the beginning of especially in the second trimester or somewhere, and has almost completed the treatment during the pregnancy, then there is a lesser chance of the baby getting infected. Whereas if you diagnose tuberculosis just before delivery or even after delivery, as in your case, then the chance of transmission increases. Okay. But these are the things that will favor or decrease the amount of transmission to the mother and to the baby during pregnancy. Then after delivery, it could be the baby could get infection even from the mother or from other persons. Healthcare workers can also transmit tuberculosis. So that when you evaluate for a child with tuberculosis, suppose an infant, newborn has had tuberculosis, then always you need to look for the source. Sometimes we may diagnose like that only. Baby can be admitted with respiratory distress, and you may get a CPNAT positivity, and you can diagnose tuberculosis, perinatal or neonatal tuberculosis can be diagnosed. Then we need to actually evaluate, look for the person from which this baby developed infection. That is very important, because the baby gets infection only from the close surroundings. If the mother is not infected, you evaluate the mother fully, including the examination of placenta, which may not be possible if you don't suspect congenital TB, or during just after the delivery, we usually don't send the placenta for exam. Do we send? Aswathy must be knowing.
Madam, if we know it prior, we will advise
Then
to
only
send.
we will be
Usually
sending.
happening another just placenta. This means after extracting placenta, then only the result will come.
Yeah, yes.
By that time, placenta might have thrown off. So we will be unable to send most of the time. We'll advise them. Means if known prior, we will send the placenta.
From the From the placenta also, not only the biopsy, you can also send for CB-NAT. From the tissue, you can get the CB-NAT positivity. And if you get CB-NAT positivity, the thing is that we can even get the drug resistance pattern. The CB-NAT also looks for rifampicin sensitivity, and also other drug sensitivity can also be nowadays done from the tissue specimen itself. The tissue can be sent for LPA. If there are a lot of bacilli, otherwise they can go send for a culture and then second-line LP and all. That is very important, especially nowadays, because we do have cases of drug-resistant tuberculosis. So it is always important that you try to get a bacteriological diagnosis as far as possible, either from the mother or from the baby. If we can get a bacteriology diagnosis, it is always better and it is always good. Your patient had only drug-sensitive tuberculosis, right? Mother had only drug-sensitive TB,
Yes.
right? So always get a bacteriological diagnosis. Okay. Anything else that you want me to explain? If there are any questions in the chat box, we can take
Madam,
that.
questions, then can we continue breastfeeding in the first 2 weeks?
You can continue breastfeeding, but the thing is that you need to isolate the mother also, maybe. If the mother is infective just after delivery, and I mean, as in your case, the mother was diagnosed only after delivery, then she will definitely be infective in the first 2 weeks, even after you start the ATT. So you can continue breastfeeding, but otherwise the mother has to follow the curve etiquette while the mother is feeding the baby, and also there should be some mother want to take care of the baby. Baby can be brought to the mother to feed. Especially another thing is that suppose the mother is too sick to feed, suppose the mother is admitted in the ICU and all, then we will not be able to feed the baby. Otherwise, if possible, breastfeeding should be continued.
Okay, Bindusha, very good presentation. Thank you. Just actually, what is said is in the tuberculosis program, Indian tuberculosis control program, you allow the mother to breastfeed the baby from the day one, starting anti-TB treatment, full treatment. Whereas American Academy of Pediatrics says 2 weeks after treatment only. So for the exams, they will be asked,
Yes.
because what should they say, answer?
Actually, being a developing country and all, we will not be able to say that baby should not be breastfed. We can say that baby, I mean, the program also says only like that. Baby should be breastfed. At the same time, we need to take precautions to avoid transmission from the mother to the baby.
Yeah, okay. And also diagnosis of tuberculosis, as you say, is always difficult, isn't it? And Bindusha, I don't know whether you remember coming out with a scoring system for tuberculosis diagnosis and all.
Yes.
And published in IP, Indian Pediatrics.
Yes.
It was so difficult. Those days we had only that X-ray and water sputum
Yeah,
exam.
we did not have this CB-NAT and all then.
Okay, so anyway, very good presentation. Thank you.
And another thing that I actually wanted to explain was the different other regimens. Other regimens for TB preventive therapy that they are not actually routinely given. Neethu said about giving rifampicin only 4 hours and also 6 months of levofloxacin. Rifampicin alone for TB preventive therapy is advised only for patients who are contacts of persons with INH resistance. Suppose the patient is having INH resistance, then you can give rifampicin only for contacts. Or suppose the patient is not able to tolerate INH also, we can give rifampicin only. And another thing is levofloxacin was another regimen which Neethu described. That is advised only when the patient is having for a contact of MDR tuberculosis, where the original person with TB disease is having a bacilli which is resistant both to INH and rifampicin. There only we routinely go for levofloxacin, that also after looking for sensitivity to levofloxacin. Otherwise, the routine regimen that we give for all patients for TB preventive therapy is 3HR in Kerala. Especially for your exams, you need to know that in other parts of the India, we are actually not giving the 3HR because your examiners may be coming from other states. Okay, so in other states, it is for less than 2 years, they are giving 6 months of INH alone, and about 2 years, they are giving 3 months of INH plus rifampicin, which is given as weekly doses.
Any doubts?
Bindusha.
Hi, sir.
Few suggestions. I think the consensus and the opinion from this talk should be recorded, documented, and should be informing the NTEP programmers, because NTEP programmer the decisions are basically taking into consideration adult. I don't know how much of the consultation with the NNF people are involved in the national programs in the NTEP. So they may not be having much experience with many of the practical difficulties and problems. So very few numbers of this sort of webinars or discussions are happening, and if at all that's happening, this documentation will not be reaching them. The practical difficulties encountered by the NNF people need to be communicated to the policymakers at the national level. That's why this presentation is so important. Few of these things which I considered during this thing is in the diagnostic part, as you rightly point out, at present, the placenta is not considered as a sample for CBNAT. So all the cases suspected or contact also, the preventive therapy for the mother, whether they have taken or not, mother having three category of these mothers are there. All the three categories make it a routine to send the pathology, the sample of a placenta for both pathological examination and the CBNAT. That should be informed to the national NTP program aspect. The second thing is the source of the thing. There are two types. One, pulmonary part, we need to consider the chances of occurrence of this thing from the family members are very highly likely, especially the father. So maybe 10% of the X-ray chest showing all these things, there is a chance of acquiring from the after delivery part, and parents like father and other family members definitely need to be included, and X-ray chest need to be done twice. Whether to affected or not to be decided on the day of the examination. After 1 month, again X-ray chest need to be done twice. That is one thing. And regarding the decision of this paracental occurrence or this thing, we are depending on the ultrasound. At present, the ultrasoundologists are not much experienced in the detection of the hilar lymph node and the radiological features. So hereafter, there is a definite need for research in two things. One thing is the radiological evidence of the abdominal portal of entry radiological findings, and there can be study including the co-guide from the radiology and a faculty in an institution where huge number of deliveries are happening. So then only sample size will be met. In a less number of deliveries happening, tuberculous mothers giving birth during this may be less. So we need the coordination from the radiology and the neonatologist, and the appearance of the radiological picture of the hilum need to be done as a research. The second thing, we are extrapolating the experience of all the treatment and the preventive therapy in the newborn. Actually, it need not be. In a previous years, pediatrics was part of the adults, and miniature adults was the pediatric and drug and dosage. Actually, it's a major mistake, because all the drugs which are used in the NTP program are designed with milligram per kg and all. That need to be the drug adverse events may be totally different in the newborn, preterm, low birth weight and all. So there is a definite need for the adverse event monitoring, biochemical and all, and that again needs a research and study all these things. And one very important thing, when you're considering drug dosage, both for clinical medicine treatment or preventive therapy, the calculation is 10 milligram per kg of INH only. or the other weight band, especially that is very difficult for the 1 to 7 first weight band, which is difficult to give. There again, unlike any other situation, the weight is fast changing. You imagine the weight gain during the first 6 months, that is a maximum. So when you're calculating and designing the weight, the dosage, you need to monitor, and the change happens to be every month, not even 2 months. So you said INH only, it should be every 2 months only. INH rifampicin preventive therapy every month. That's not right, because by 2 months, the weight gain will be much higher. So the change in the weight pattern should not be equal to another person, and the newborn period, you need to take into consideration that. And other thing is fast gain in the weight, weekly rifampicin, drug toxicity person. Isolation and breastfeeding, I think we need to have a clear-cut idea, because it's not a light decision, because if you are putting the mother without feeding in the first 2 weeks, that means almost 90% the breastfeeding will not be established. You are branding it for an artificial milk. So whatever risk, the prevention from the baby to the mother precautions should be taken. If the mother is not sick, if the mother can feed, even when there is a possibility of bacilli in the bottom, cough etiquette and very good mask to prevent the transmission and encourage breastfeeding. That should be a better policy for our scenario, not in the European countries. Okay.
That is what the NTEP recommends also, sir. There was one question. After completing TPT, should we again investigate the patient for active tuberculosis? Any patient in whom we are giving TPT, they should be kept under follow-up, not only during the course of TPT, even after that for a minimum of 2 years. Nowadays, they also recommend 5 years for younger children. They have to be kept under follow-up, and they have to follow up by looking at the weight and also looking for any features of active TB disease. If the patient has develops any symptoms suggestive of tuberculosis, then we need to evaluate again.
Thank you, madam. Regarding the fixed drug combination, actually we are following up the patient every 2 weekly. And usually, even though we are getting the drug from NTEP, we may have to crush the tablet, because most of the time the fixed drug combination cannot be used as such. So usually we need to start with 1/3 or 1/2, then that we will crush. And now actually our NDEP, they give instruction to the peripheral hospital through the Nikshay portal, and also there is a letter given to the peripheral center near their home regarding the mother and the baby to get followed up. But drug will be given from the medical college itself till the baby is 4 kg. After 4 kg only, it will be given from the periphery. Till that time, the baby will be kept under follow from the medical college. Every 2 weekly, we will check the weight and adjust the dose of the drug, and also will monitor for side effect.
And one more thing regarding the contraindications of this TB preventive therapy and other, one of the point mentioned was the liver dysfunction. Actually, I think there are many reasons for the transaminases and the bilirubin to be high in the initial period for many of these preterm and the sick babies, and also whether there should be a cutoff for the transaminase, maybe 5 times or 3 times a transaminase or like that. That need to be, rather than blindly say that liver dysfunction, because there should be an acceptable limit of this thing, because weighing the pros and cons.
If there are no other comments or doubts, shall we wind up the program? Dr. Arun?
Thank you. Thank you, Dr. Aswathy, for brilliantly moderating the session. And especially Dr. Bindusha, who's given a lot of views and expert opinions, and all the other senior faculty who has contributed. I, for myself, understand that this, like Sir mentioned earlier, that it's easier to follow in a medical college setup, but a lot of knowledge and know-how and the practical aspects are lacking, especially in private setup, especially because you see less and less of cases coming, and the one-off cases might be initially treated as TB and then initially treated as sepsis, and then you probably miss out on all those as well. So it was very enlightening and I think very useful for all faculty and practitioners also. So very important session. And Dr. Aswathy only suggested this topic because perinatal TB is something which is not commonly seen by everyone. So thank you for that wonderful session. And I thank Dr. Aswathy for moderating, Dr. Bindusha for giving time, especially on a holiday, to come and give her opinions and her experience with regarding to treating TB, and Dr. Purushothaman sir to adding, like always, adding few tidbits for practical aspects with from his experience, and PMC sir for his enlightening opinions as well. So thank you, and
Dr. Neethu for presenting.
And Neethu, especially we have to be thankful that she has to. I'm sure she's not given an option, but it is very brave of her to come forward and present in front of 50 to 100 people and give at a short notice as well. So thank you, Neethu. We've all been there, and I think the young people will take turns continuing to enlighten us as our journey also. So thank you all for this wonderful session, and hopefully we will need to meet you next week for the next session on PG Club. Thank you.
Ashwathy, thank you, Neethu.
Thank you, sir.